First of all, there's the distance. Even if there are providers to get to, the patients have to travel. They often don't have a car. If they do have a car, they don't have much money and they can't afford the gas. And then there's the time involved, especially a specialty provider like a psychiatrist or child psychiatrist. They may have to drive 100 miles, which is a real barrier. Second is just not having enough providers in general. In general, health professionals prefer to work in urban areas as opposed to rural areas. It's even more so with specialty providers. And the mental health and substance abuse treatment agencies in rural areas face real workforce recruiting challenges. The number of psychiatrists in the country is actually dropping. There are more psychiatrists aging out of being in the career than are coming in through new training, and the workforce shortage is getting tighter. We've had hospitals in rural areas actually close because they couldn't hire psychiatrists to staff their units, and now the sheriff has to drive somebody an extra 60 miles, and there's only 2 deputies in the county, and now they're down to 1 because they're out for the whole shift driving 3 counties over. Workforce is huge and really deserves legislative attention, particularly in the areas of psychiatry staffing. Another issue that rural populations have that's a little different than urban is their ethos of being individuals, and you ought to deal with it yourself. And this is very good when you are not impaired with an illness and when you have good capabilities, but when you can't think straight because of a depression or a mania, or whether you're considering killing yourself or harming someone else because you feel so miserable, toughing it out by yourself is not a good choice or solution, but it is often the preferred solution in rural populations. Missouri was the first in the nation to have an approved CMS plan to implement health homes, both in community mental health centers and in primary care clinics. Mostly the federally qualified health centers were statewide and both around the state. So I'm often asked, what is a health home? Well, a health home is, in a way, 2 different things. It's a way of delivering healthcare services, and it's also a funding mechanism, and I'd like to talk about those 2 separately. First, as a healthcare delivery method, a health home is a practice, a healthcare provider that not only gives the particular care they do, whether it's primary care or mental health care, but they also take responsibility and are accountable for the whole range of health care a person gets, and accountable for the health care they don't get, for the gaps they don't have. One major difference between a health home and managed care is managed care focuses almost entirely on overutilization. Are you going to the ER too much? Are you going to the hospital? And they mostly do that by communicating with the provider, the hospital or the doctor, saying, don't do that so much. No, we won't pay for that. It's about overutilization, and it's a communication with the provider. A health home is more about underutilization. It's about identifying the care you should have gotten that you didn't get, which actually ends up keeping you from going to the ER and the hospital in the long run anyway. So it is a population-based, data-driven approach to delivering medical care, as opposed to the usual cottage industry approach where let's wait for the patient to complain and then take care of that thing one at a time, which is not an efficient way to take care of people with multiple illnesses and very expensive care. Health home as a funding mechanism is particular to the Accountable Care Act. There's a section in there called Health Homes for Persons with Chronic Conditions. It's Section 2703, and it allows for an enhanced federal match of 90%, 90-10 match for the first 8 quarters, for the first 2 years that a state stands up a health home. It's a really cool funding opportunity because the state gets to define the services, they get to define the provider group, they get to determine their own rate. The feds has given broad flexibility in how a state wants this specifically to meet their need. Now that said, people shouldn't think that they can't do health homes if they're not going to do Section 2703. Missouri was doing several prior initiatives that was really the same approach to service, that health home approach. We were just using different funding mechanisms. So this is a really great funding mechanism, but it's not the only way to skin this cat. So in terms of outcomes to the programs, the health home program we started in January of 2012. So it's been in place about 18 months, which means we're able to evaluate about 12 months of data due to the lag in getting data and claims paid and all that. We're seeing reductions in hospitalizations. We're seeing reductions in readmissions. We're seeing improved clinical indicators such as people that have their hemoglobin A1C, a measure of blood sugar control, in the acceptable range, or people that don't have as much hypertension. Modest so far, but it's only a year in, and the experts will tell you in here a year is really early to be reporting outcomes at all. So these should be viewed as rough. On the fiscal outcomes, the primary care health homes are almost breaking even. The CMHC health homes are saving in the neighborhood of $120 to $200 per person per month. That's because they had sicker people to begin with, as I mentioned before, that you can save more if you're spending more to begin with. The other learning that's been important is this is a heavy administrative lift. States should not underestimate the staff they will need to do it or the health information technology they'll need to do it, particularly if they want to be doing it with actual lab values, weights, blood pressures, getting the individual clinic numbers in centrally, as opposed to just having the practices say, hey, we're doing okay, trust us there. It is a complicated data lift. It's actually made me much more sober about the health information exchanges because they will face the same problem of aggregating data and getting clean data that all has the same format in one place. It's been tough and it's taken us longer than we thought it would. The other interesting learning is the practices are enthusiastic. We thought that they would say, oh my God, this is too much work, we're out of here. They are energized, they like doing this, they see a vision of a way to do things better, they want to do more of it, and they are working harder than we've ever seen them work. This has also helped us align our incentives between the agency as purchaser and the providers as payer due to some of how we structured it. So we're having less bickering and more hard work, nose to the grindstone stuff. Very refreshing. A couple points I'd like to add related particularly to rural health care, and I'm intentionally saying health care, not just mental health care. We already mentioned the difficulty getting specialty care in rural areas. For that reason, even more in the rural areas than the rest of the country, most of mental health care occurs in primary care practices. And I haven't said much about our primary care health home. Both our primary care and our CMHC health homes focus on integrating behavioral health and primary care. And in both cases, we looked at the gaps and gave that practice what they didn't have. I think that, we need to go where the patients are rather than build new places we expect patients to go. I think we do better when we find them where they are and give them the services they need. I think probably the biggest remaining shortcoming is our ERs that are full of people with substance abuse and mental health issues, but we do not require ERs to staff for those. If you had anywhere near the number of pregnancies and broken bones in ERs that you have people with substance abuse and mental illness, you would insist on there being more obstetricians and orthopedic surgeons. But we seem to be fine for decades of having ERs full of mentally ill people and substance abusers, yet we do not staff for it. We tell the patients to go elsewhere. We've tried this strategy for 30 years. They have not gone elsewhere yet. And we need to have a different strategy other than telling them to go away. Instead, we should have those services there for them. That's where they are. That's the easiest place to put the services.